Yes, so in the next 20 minutes, I'm going to talk about the disease relapse and progression. Mainly relapse, since Axel will be talking a lot about the progression in the more clinical sense. So how does that work? Like that. So I'm starting with actually one of his paper, who nicely shown. So here, if you look at how sick patients with plaque psoriasis were at onset of the disease and then after 10 years, you see that many of them stay in the same category of disease severity, as some of them will change, of course, we know that. But within the same category, we know that it doesn't look that smooth, and that it's more likely looks like that, with this kind of circle of relapses and remissions through time. So how does that work? What do we know about these circles of relapse and remissions? So we know that we can treat psoriasis most often, and that it has a tendency to come back at the same spots. That was also nicely shown in a recent paper, showing in red here you have the previous plaques before treatment of that patient, and then in the green dots are the relapse spots. So you see that it overlaps with the previous disease, and that was, of course, known, but it's a nice illustration of that phenomenon that we know. And that raises, of course, the question of disease memory. So, and I know that we all remember these beautiful papers from some years ago now, showing that if you take non-lesional skin from psoriasis patient and you graft it on mice with immunocompromised mice, you will have the development of full-blown psoriasis. Yes, so that's shown here. And this was not like non-lesional skin, it was non-lesional skin with some infiltrate already. So some activity, some immune activity in the dermis. And what was shown back then is that if you block the transfer of these immune cells towards the epidermis, you will not have the development of the disease. Showing here that the skin compartment and the epidermis are very important for the development and for the sustainment of the disease. So here you have some papillomatosis index after 1 month of graft, and you see that if you block the migration of the cells toward the epidermis, you will not have the same development of macroscopical disease. And of course, I'm not saying that psoriasis is only a very localized and skin disease. We know that, especially in severe psoriasis, you have circulation of pro-inflammatory immune cells. You will have a higher level of cytokines. But what we know as well is that blocking the migration of circulating immune cells to the skin is not enough to stop the development of psoriasis. So the skin compartment in itself is very important. So what about the resolved skin? So here they call it cure skin, but we know that it's not cured, right? It has some disease memory. And there has been many studies, especially since the transcriptomic era, showing that resolved psoriasis retain expression of disease-related genes. That's one example. After 3 months of TNF blockers, you have a total resolution of the pathology, but you have a persistence of transcriptomic changes. And then I'm going to pass on that because I think we'll be a bit short. But I wanted to show you these, not new papers at all, so 40 years ago, because it's difficult when we talk about resolution and remission. We often talk about treated psoriasis, but it might not be the most useful model to identify what makes the resolved skin stay resolved. So here in that paper, from '84, they had gutati psoriasis, that is self-healing form of psoriasis. And they looked through 16 weeks from active lesion to the resolved lesion. And what you can see here is that you have an increase of the CD8 cells and a decrease of the CD4 cells. While if you look at treated psoriasis, that example is PUVA. So PUVA decreases every immune cell types. But you see that you will have both a decrease of CD4 and CD8. So resolved skin, I mean, it depends what's the treatment and how it's been resolved. And it's not that many data about this kind of spontaneous resolution. I'm showing you that paper, that's mass spectrometry from last year. And so they looked at all these markers, and they had a nice setup. So they had patients that were sampled both in lesional, non-lesional, and perilesional skin, and one of the patients was also sampled on cured lesional, so resolved skin. So these patients were, as far as I understood, untreated. So that's also interesting because it's resolved skin, but not under a systemic treatment. And what they could see here, so you have this kind of equivalent of PCA plot. In the dermis, it's, as usual, quite mixed between the non-lesional and the normal skin, and the lesional and the perilesional. It's not that easy to differentiate them. They don't cluster well, they cluster together, basically. But in the epidermis, you have the lesional epidermis here, and then you have the normal epidermis from non-psoriasis people, and the non-lesional epidermis. And then here you have the perilesional epidermis, and you see that it's moving between the non-lesional and the lesional epidermis, depending on how active probably the lesion was. And here you have your cured lesional that clearly belongs to the perilesional, so it shows you that something is going on here. And the cell type in the resolved skin that has caught most attention, even though it's not the only one at all, are T cells. And almost 10 years ago, it was shown that following anti-TNF, anti-IL-20, anti-IL-12/23, and UVB treatment in the epidermis, not in the dermis, but in the epidermis, you had CD4 that kept the capacity to produce IL-22, and CD8 that kept the capacity to produce IL-17. That's in gray here, the IL-17. That is active lesions, and these are the three treated groups, and that is IL-22 in blue. So the T cells are still doing things in the resolved skin. And that was, of course, a couple of years later, a beautiful paper showing the clonality of these T cells, and that they are also in non-lesional skin, but in a smaller proportion. So cellular scars in resolved psoriasis, it's not only T cells. Here you have an example of Langerhans cells that after TNF treatment still express more IL-23, and after UVB treatment still express more IL-15. And you also have epigenetics memory that I didn't go into today, and dermal disease, and also an increase of IL-10 producing Tregs. And fibroblasts, we don't know yet, probably doing things as well. So, but again, these studies, I mean, what we know about this topic comes from treated skin mostly, and from different treatments. So it's difficult to draw conclusions and extrapolate to all resolved skin. And also, I mean, we are interested in resolved skin because we want it to stay resolved and not get the disease again. So how can we use this knowledge about this disease memory? So we tried some years ago to use these T cells, memory T cells in the epidermis as relapse predictors. So what we did is take biopsies from patients after UVB course. So normalized microscopically, but some disease memory inside, of course. And if you look at the transcriptome, we couldn't really correlate it to the time before relapse. That's in months. So here you have 1 year somewhere here. So there was no correlation. But if we took the biopsies from the patients and activated T cells inside the biopsies with OCT3 antibody, we could see a nice correlation using actually very few markers, like 6CL10, and then the IL-17-driven defensin beta-1 and small prolines, 2B and 2A. And we had a nice correlation with the time before relapse, because we know that after UVB treatment, they do relapse. And that was also the case at the protein level. And interestingly, IL-10 behaves like CXCL10, so that the more IL-10 was released around the biopsy when we activated T cells, the longer time it was before the relapse. So we thought, great, maybe we have something here. Maybe it's going to be the same after biologics, and then we can help the clinicians and the patients to know when to stop the treatments, when not to stop, and when to, Of course, that would be very useful. But using the same markers, it doesn't work. So And that data is not published yet, so we will dig into it more. But this little system is not extrapolated to all the treatment of psoriasis, which is not a surprise, but it would have been nice. And there are other predictors for the relapse, but not that many. I mean, usually the predictors you will find is for the responses to treatment, but not really the relapse, the time before relapse. And in that study, for instance, PASI improvement, like basically a low efficacy or bio-experienced people were predictors of shorter time before relapse. So that's also interesting, more clinical information. And back in the days, also the Koebner phenomenon after UVB treatment was if you still had an active Koebner, that would mean that the disease would come back earlier. But yeah, we don't have that many stuff. Okay, so we have a disease memory, and we know it's not only T cells, but much of it is in the T cells that are retained in the epidermis. So what could we do? Could we change the populations of the T cells? So basically here you have, what I represented here is like you have resolved skin, but it's still a lot of IL-17 producing cells. So could we do something more than the current treatments we do, to have either a shift in the population of T cells, or just decrease the number of these disease-related T cells? And of course, the aim is to decrease the relapses. So what are I don't have an answer to that, but what are the targets, let's say? So one obvious target would be the skin microbiota. So 10 years ago, the lab of Yasmin Belkaid, published with Trudy Naik, published a beautiful study showing that the Staphylococcus epidermidis on my skin could change the population of T cells in the skin. Beautiful papers. And a couple of years back, Charlotte Urabiel in the same lab showed that here, if you expose mice, if you expose mice to fungi, Candida albicans, Malassezia furfur, and Trichophytum, my skin, to these fungi, you will actually then, when you expose the mice to the imiquimod model, that I think you're all familiar with, it's a very classic model of skin inflammation for mice models, you will have actually a stronger inflammation. So in blue here, you have the imiquimod model, and that is ear thickness. But if you have primed somehow the skin with this fungi, you will have a stronger inflammation. So here you have an example of bugs that will make the subsequent inflammation stronger. But you could also imagine the contrary, like some bugs that would create a different type of T cells population in the skin that would be more regulatory. And actually, there are some beautiful data out there. That's a study from Elizabeth Grice 5 years ago. It was linked to a trial. And they had this kind of dose interval determination period, and thereafter suspension of the treatment until relapse. So they have like skin microbiota during the treatment and even at the relapse. So that is very, very interesting data, and different body sites. And so yeah, very, very nice paper. But of course, it's only so much you can write in one paper. So they didn't decipher too much the microbiota as a disease relapse predictors. So if anyone has this data, please have a look at it and tell us, because that would be very nice to know. And another target would be the fatty acids on the skin, because of course I'm showing you microbiota and fatty acids because that's the things that are on the surface and that could be modulated quite easily compared to other things. So we know that the resident T cells in the skin, they need to be able to intake fatty acids in order to survive there and to fulfill their function, because the T cells in the skin, I mean, I'm talking about psoriasis, so they sound bad, but their primary roles are more like protection from microbes and from cancer cells. So they couldn't work as they should if they didn't have the capacity to intake the fatty acids. And what we did is to have a look on normal skin, because was not enough skin on the patients to fax that, to do flow cytometry. But on normal skin, we have a nice correlation between the proportion of the T cells that actually express these receptors for the fatty acids and the class of fatty acids. So here you have omega-3, omega-7, omega-9 on the skin, and you see nice correlations with these markers of T cells. So there is some interconnections. We don't know how, but something is going on here. And what we did as well is to, on the patients this time, to take resolved skin and non-lesional skin, activate the T cells, as I showed you before, and do some nanostring analysis. And we could see so this is resolved skin, this is non-lesional. So in resolved epidermis, these IL-17 related markers, small prolines 2A, 2D, and defensin, were inversely correlated to one fatty acid, that is oleic acid. So the more oleic acid you had on the skin, and the milder the upregulation of this factor were. So showing that there is some kind of interconnection again between the lipids on the surface and the function of T cells in the epidermis. Again, there might be a big bias here because oleic acid is a byproduct of malassezia, so maybe the effect we see is not, is biased by the microbiota. It's just like a change of population on the skin, and maybe it's the malassezia that actually acts on the T cells and not the lipids. It's possible, so we have to look into that. And I'm just showing you that fatty acids might have other use. Here you have the time to relapse in months, and the proportion of certain fatty acids, so C12, C25, C26, and you see that the time to relapse differs depending on if it's high level of detection or low level of detection. So in conclusion, what do we know? We know that resolved skin relapses more than the rest of the non-lesional skin. The disease memory involves several cell types, and probably there is a whole imprinting of the whole epidermal compartment, and there is still a lot we don't know. And skin T cells are part of the disease memory, but there is no definite proof of their causal role in the relapse by themselves. And of course, it would be very nice to have single-stage data on resolved skin. This year we've seen beautiful papers, so that would be amazing to have also this kind of analysis and this kind of details in resolved skin. So what to do? I think the interesting perspectives are also, again, epidermis and dermis are different, and we know very little about the dermis and the fibroblasts in that setting, so that would be very interesting in the coming years. And then understanding the spontaneous resolution, as I try to introduce to you, as it might differ very likely from the treated skin. And maybe that's the kind of resolution that is the most relevant. And changing the memory, T cells, and also epigenetic changes that can be modulated. So with that, I'd like to thank you for your attention.
Thank you very much.